Integrity installation failed.
No, don't worry about that. You can just close that window. That's
bogus. So, welcome everyone who's joining us for Kodachromes, and this is where we left off last time. It was a patient with Strongyloides larvicurans. Point was just made that whereas larva migrans is commonly on the extremities, except in the cable guy who has to crawl into the house, larvicurans tends to be truncal, and especially periumbilical, thumbprint purpura, the linear, rapidly moving tracts of larvicurans, which can come from the perianal area or on the abdomen. So strongyloides sepsis. Okay, this one I don't think we've done yet, right? Okay, Brian, you want to start us out?
Absolutely. So, looks like there is a kind of brownish, maybe a little bit of violaceous, patchy area along the anterior hairline, extending along the cheek as well.
It's beautiful. And so you said brown and violaceous, so you put those together, and what might you expect histopathologically?
Violaceous makes me think lichenoid.
So some kind of lichenoid process, most likely.
Right. The brown
right?
makes me think of maybe some like melanin incontinence or like a more chronic process.
Yeah, so PIPA from a later stage lichenoid process. Very good. And the guy is what ethnicity, do you think? Maybe hard to tell.
Yeah, hard to tell, but I'd give him like a Fitzpatrick 2 or 3 maybe.
Yeah, it's some olive type of skin. Okay, so it's biopsied and sent to us because it's biopsied and it's read as lentigo maligna. And you can see a few large plump melanocytes here, and then these nesty things. And there's a MART1 melan strongly positive.
Mm-hmm.
So what are you thinking? Is it kind of where you were going clinically?
No. I don't think so.
Call in. You will be each other's support group for the rest of your careers. So call in Dr. Eccles, your brilliant dermatopathologist, whom you call for help.
I thought that the multinucleated melanocytes like that were good for like a congenital lupus.
You can see junctional starburst giant cell if they're melanocytic. You can also see in lentigo maligna. There's an S100. So, Tom or Ashley, what do you think?
Pseudonest.
Yeah, so it's pseudonesting phenomenon, which you see in Lichen planus actinicus. So, go back to your clinical, and it's clinical often trumps path. Or redirects path, may be a better way to say that. So back clinically, you were thinking this was a lichenoid process. It's an olive type person, so LP actinicus would be right in there, sort of an ashy dermatosis sort of picture. And that's where lichenoid pseudonests have been described. These are actually melanocytes. They're plump, sun-damaged melanocytes, but they've led often to a misdiagnosis of lentigo maligna because they're aberrantly MART1 positive, can be SOX10 positive, can be MITF positive. The only one that they don't stain with is S100. So that's probably the one to confirm with if you're looking for pseudonesting phenomenon. So LP actinicus, melanate positive pseudonests, leading someone to suggest the diagnosis of lentigo maligna.
Mays Jr. did a big paper on the pseudoness. Like magic bullets.
I think when he was at UCSF, correct. And that's where it was first described on the cover of the, I think it was American Journal of Derm Path at the time that it was on the cover. but it has since been, described in a variety of things, and it's not just SMART1 melanae. It's every melanocytic stain except for S100, and there's one other, the SAC, the soluble adenyl cyclase. That one has not stained with them. So that's another one you can use for backup. Okay. Christina, what do you think? Okay, so racemose livido doesn't fade like acutis marmorata and has broken rings. So livido is net-like, and racemose livido has broken incomplete rings. No, I think it's racemose. I think it's incomplete here. I think they're broken. I think you're right.
So different things like a vascular occlusive involvement on that side versus, some sort of vasculopathy. So, do they have phospholipid? Do they have PAN? Do they have Sneeden syndrome? Like cerebral aneurysms I should be worried about? Like that kind of thing.
So you brought up PAN, Sneeden. When you have a livido pattern, you're thinking of something vascular occlusive, which can be embolic thrombotic or larger vessel vasculitic, like the PAN group. If it were someone who started already in very young age or childhood with a Sneeden-like picture but had PAN on biopsy and early onset stroke, that's a newly described syndrome. That's an adenosine deaminase deficiency. So adenosine deaminase can give you severe combined immune deficiency, but it can also give you this horrible syndrome where kids start stroking at age 5.
Dada syndrome.
Is it?
Dr. Cowan from NIH was talking about it at Durham Foundation.
Okay, so Ed Cowan.
Deaminase 2, I think.
That is correct.
He pretty much showed the livido racemosa, said it's like Sneden's in kids.
Okay. So, I mean, that's exactly right. And NIH Grand Rounds, which Ed does for the JAD, will be covering a feature on it. Because it's an important one to recognize. And what Ed actually brought up in that is how many of the people that we've classified as Sneden's and looked for antiphospholipid and didn't find anything might actually have that. We recognize it in the kids who start at bizarrely young ages, but how about the adults? We're just not looking, and maybe it's more common than we think. So that's actually an excellent differential. If you were going to biopsy, where are you going to biopsy?
Well, it looks like we're biopsying one lesional and one that's also very lesional for DIF in this picture.
Yeah, so, or not for DIF, but for sampling. And the issue here is, where are you likely to find the occluded vessel? The occluded vessel may be in an infarctive stellate area or in an area that's not getting blood and appears pale rather than red. Some of the red is just reactive hyperemia, blood shunting away from where the blockade is, and others are stellate infarctive areas, and sometimes you just can't tell which is which. And so in that case, you go for a pale area, and you go for what appears to be maybe a stellate infarctive area, trying to find your occluded or involved vessel. Here's another patient with pronounced livido pattern, and I believe both of these patients ultimately proved to have PAN, polyarteritis nodosa. Okay, Sean.
Okay. So I see 2, maybe 3 kind of little flesh-colored papules here. I don't know if we're talking about.
Yeah, and there may be even a 4th or 5th, like 1, 2, 3, 1 excoriated, or a couple more, very discrete.
Yeah,
so what are you thinking?
Very flesh color with some surrounding erythema at the base. Look like that one may be excoriated, so they may be pruritic. differential is pretty broad. I mean, this could be arthropod, sol,
So arthropod, absolutely. What else?
like something like a dermal edema type of thing. Like a dermal hypersensitivity, almost urticarial type reaction.
So like a papular urticaria. I mean, they're very discrete, right? Other thoughts? Anyone want to chime in? It's a little too discrete for ordinary rosacea, but acne agmenata, lupus miliaris disseminatus faciae, can absolutely look like that. The other thing that has a huge spectrum of how it looks that can look just like this is Rosite Dorfman. Can look just like that. It's going to be a biopsy diagnosis. And that's what you see on biopsy, so what are you thinking?
That looks like
So palisaded, I'd say this is a little rounder than deep GA tends to be. That tends to be a little more stellate in the center. And this is probably caseous rather than fibrin. And so with the histology, this would look like a little caseating granuloma. So back in the days when tuberculosis was common, you would assume this was disseminated miliary TB of the face. How would you say that in Latin? Miliaris disseminatus faciae, right? Because lupus meant TB, like lupus vulgaris. So lupus miliaris disseminatus faciae literally means disseminated miliary TB of the face. Just like mycosis fungoides means a fungating mycosis. They're all misnomers. So this is caseating rosacea, not disseminated miliary TB of the face, but the old name lupus miliaris disseminatus faciae literally means disseminated miliary TB of the face. And of course we know that's just acne agmenata miliary TB. And this is from Larry Gibson at Mayo, another patient. And you can see again how they're very discrete papules. You might look at this and think of something like syringoma, but acne agmenata can also look very similar to that. Okay.
So we have an atrophic patch.
Yeah, and you know it's atrophic partly because you're seeing capillary, subpapillary plexus here, and you're seeing reticular veins very prominently. This is probably a crease, like a crease in the planus area. Bless you.
It's like a trophoderma of
So atrophoderma of Pacini and Perini is a good thought. Often that's a little brownish, sometimes with a little lilac morphea-like border.
like Lyme disease.
Lyme, acrodermatitis chronic atrophicans would be, which is not always acral, is sometimes truncal. Those are excellent thoughts. The other thing, common things being common, this guy or woman has been seen by their primary care repeatedly for this irritation in their flexures, and they keep getting prescriptions for what?
Steroid.
Yeah, and specifically, what do they keep getting from primary care? Like, or Lotrazone. So Lotrazone is the work of the devil, and it has the antifungal in it is not bad, but the steroid is just too strong, and so we see a lot of the ones we see are all the complications. Not that it can never be used appropriately, but we see all the complications. So we see the long-term atrophy, and we see the Mycosis fungal granulomas that it creates. So that's Lotrazone at work. Okay, David.
So, loss of the eyebrow, erythema as well.
So with or without visible scarring?
I see some visible scarring.
Yeah. I think there's contour defect and there's color change. It appears white. So what things might you think?
So like malignancy is an infiltrated process like follicular MF, which is what mucinosis maybe.
So follicular mucinosis, follicular tropic MF, although they're less likely to produce scar, white scar. And you may be more likely to see a comedone-like opening where those follicles, you squeeze the comedone and you get a little jelly out of them if it's follicular mucinosis.
LPP.
So lichen planopilaris, okay, now I think you're cooking. What else? Along with LPP, what else loves the eyebrows? Lupus. And anytime the word lupus leaves your mouth, what has to go out with it? Cousin to lupus, but you have to worry about internal malignancy. Dermatomyositis, absolutely. So that's kind of your differential. You'd look at this and say, LPP, maybe that's usually more like a Graham-Little Picardy, where you lose your hairs, but you don't see interfollicular scarring. Interfollicular scarring is more likely just statistically lupus or DM, because they tend to hit the intervening dermis, whereas LPP is more sniper fire that just takes out the follicles without surrounding scar. This one, however, on biopsy was LPP, exception that proves the rule. That's part of why we have these pop up, is sometimes it's a little bit of a surprise, not what you were thinking. Statistically, I'd go a little less down that route, and I would be inclined to review the IF and make sure that this really is LPP and not a lichenoid lupus.
LPP just affecting your eyebrows and not giving you like any frectal diversity alopecia or other hair loss. How common is that?
So LPP just on the eyebrows, less common. More commonly, you'll see scalp involvement or frontal fibrosing. And again, it's more likely in the brows to be a Graham-Little Picardy where the hair is gone, but it doesn't really look like a scar, even though it's permanent alopecia. Whereas lupus is more likely to give you a scar-like appearance. So just statistically, lupus would have been a better answer for that than LPP, although that's the way it was submitted as the final diagnosis. Some of these are not. Some of these are contributed images. They're not mine. Okay. So Jessica, what do you think?
Very well demarcated. Erythematous sort of looks violaceous to me, black. I can't tell in the center if there's microvesiculation or is it.
I agree. It looks like either follicular prominence or microvesiculation centrally, and then is it uniform beyond that?
No, it looks like there's an area of clearing.
Area of clearing, so somewhat targetoid or an initial lesion and then a secondary expanding migrating lesion.
So I worry about erythema migrans.
So erythema migrans I think would be 1 through 20 on my list. You'd have to think of other gyrate erythemas and other things as possible, but this is more likely the initial exaggerated bug bite response, and then this is the erythema migrans going outward, is what I would think, and that is in fact what it was.
This looks like an angiokeratoma.
Looks like an angiokeratoma, exactly. That's exactly what it looks like. And then if these were clear, so they looked like frog spawn or little fish eggs, then that would be a lymphangioma circumscriptum, which is the lymph variant of the same thing.
Are we looking at the lone lesion or the...
Well, you're looking at the patient, so...
Well,
so which one would you biopsy? Hopefully the very, very dark one.
Black.
So this is a series that I think was courtesy of Robert Wood Johnson.
Okay.
The residents there, Omar just graduated from that program. And So I think the series we've been looking at here came from them.
Right. So this obviously I think would be worried about any kind of melanocyte class as melanoma at the top.
Absolutely. And there's your dermoscopy, which is, shows you the pigment network, the globules. There's a milky veil, red, white, and blue. Lots of things that don't look good. Okay, another patient.
I think MF would be very high on my differential.
So I agree. Mycosis fungoides would be your top 20 for this. MF historically has been a working man's disease. Disproportionately hits African Americans and people who are not in the highest socioeconomic groups, although it is disseminating more in the population. And so a lot of evidence suggesting that it may be a retrovirus that continues to spread, and spread first in some communities and then more widely. But you still see it disproportionately that African Americans are affected. Truncal bathing suit areas that are poikilodermatous greater than 5 centimeters. So.
So, think about EAC.
So erythema annulare centrifugum. Is the scale trailing?
Decide if there is much scale. I guess that little dot right there.
Yeah, I think there is scale, and it's distinctly not
That's scale.
trailing. So EAC would go down on my list a little bit.
Think about tinea.
So tinea, absolutely. Other things that, and I think it was biopsied because it was KOH negative, and the patient had multiple lesions. Mycosis, psoriasis, things like granulomatous and deeper gyrate erythema, I would tend to discount because of the scale. They don't tend to have scale. The other thing is gyrate erythemas like this you can see with syphilis and you can see with mycosis fungoides. So, keep syphilis and MF in your differential for weird gyrate rashes, and this one was mycosis fungoides.
So we have a tattoo, a little bit of erythema on the right.
And what's happened here?
So it looks like we have, I guess, areas that the pigment has been removed.
So pigment removed or some sort of adnexal structure filled with something.
Right. So like, something like milia?
Yeah. I mean, that's what I think is this is probably a new tattoo, and those are post-traumatic milia in a new tattoo is my guess.
Is this area of the tattoo like raised, or is it just the way of the shadowing of the tattoo?
There may be a little raised, and it may, reds in tattoos are often fraught with difficulty. They used to be carmine, and now they're more organic dyes, but still orders of magnitude more than other pigments associated with allergic reactions. And it may be going a bad direction, and I'm sure the patient came in because very proud of the tattoo and very concerned that something's going wrong with the tattoo. I think the milia will fade, but this may portend allergy to the red dye.
Erythema, swelling as well.
And colors besides erythema?
A little bit yellow.
A little bit yellow. So what would give you yellowy pink bumps on the areola?
Sebaceous.
Yeah, ectopic sebaceous glands, or not really ectopic, but hypertrophic in an area where they're supposed to be. And so what are they called? Anyone? Montgomery's tubercles. And we had another patient at East Cooper who just has really, really prominent ones. So there'll be another photo coming in a future session of that one, because she was really bothered by them. They were new onset. Okay, this was also contributed.
So you have these brown nodules in the extremities. And then some genoderm process.
So you think of genoderm. You also see people, though, with eruptive nevi and spitz nevi and things like that. That probably is a gene mutation in those people. And this was from Whitney High, and it's just all congenital nevi. And again, even here, you can make out what's probably loss of heterozygosity. So there's a mutation here that's driving that. And then you have exaggerated Blaschko type segment that probably has loss of heterozygosity of the gene. So we know that many melanocytic proliferations are driven by NRAS or BRAF or other mutations.
So I think this is the blue sclera you can see most classically with like osteogenesis imperfecta.
So blue sclera, and you think of things like osteogenesis imperfecta. You can see it with PXE. There Marfans, you can see it. But most classically with osteogenesis imperfecta. If there were some pigment on the adjacent skin, then you think of nevus of Oda, correct. And in this case, it was nevus of Oda rather than with, I'm not picking up a lot of pigment in the adjacent skin, but. Probably an axillary fold, right?
Yeah, it looks like what we have around the axilla looks to be normal skin with a surrounding kind of confluent erythema, macular. Like,
yeah, so you got a flush or a flare type response.
I mean, I think the differential for this would be pretty broad. You could think drug and viral, any kind of, like you had said, flushing etiology, whether it was medication, food, or like syndromic, like carcinoid, pheo, any of those.
Carcinoid, pheo, histamine. You'd need more history of whether it was episodic, and this one was a niacin flush, so drug. And we have the ongoing debate about whether niacinamide does it. I have definitely seen it in patients with niacinamide as well, but the incidence is lower than with niacin. So Necrobiosis lipoidica, maybe granulomannulary as well, but with yellowy shades, maybe more likely NLD, and that's exactly what it was. And this is the more advanced NLD. This looks like an arm, not a leg, but you certainly can get it elsewhere, and it's not always D, so sometimes we just refer to it as NL, Necrobiosis lipoidica, because the patients aren't always D. So a baby or an obese adult with a diaper. And an umbilical hernia, yes.
Interesting. This looks like, again, like a dermal edematous type process with central pallor, how that urticarial type of process.
So urticarial type of process, they're definitely ring-like annular lesions. So in the junior set, when you have ring-like annular lesions, what kind of things do you have to think of?
Like deep GA, maybe.
So deep GA, although not necessarily an infantile process so commonly. What annular thing would be really important to pick up in a baby? Anyone want to jump in? Neonatal lupus would be probably the big rule out. It can be face, but it can also be trunk. in someone who's a little bit older, erythema marginatum of rheumatic fever. But in a baby, especially a baby between 6 weeks and 6 months of age, 6 weeks to 6 months, is your window where neonatal lupus usually shows up. That's why it's not congenital lupus. It's congenital heart block, which may not have been identified. But the rash is not congenital present at birth. It's neonatal present between 6 weeks and 6 months of age. And that's what this one was.
This is a basic question, Dr. Elston.
Sure.
But I know a lot of the books say like these kids get better pretty quickly. Is it lupus of the infant, or is it passive antibody transfer?
It's passive antibody transfer from the mom.
So once those
So it's the row. I mean, it's not just row. There's SSB and other RNP and other things that can pass, but row is pathogenic in terms of the heart block and pathogenic in terms of the rash. And it is maternal IgG, which is why it tends to resolve by 6 months, because that's about when the maternal IgG is gone. And tends to beat on your heart conduction system and then tends to beat on your kidneys. Is that it? Liver, not kidneys, for neonatal. So they have hepatitis and not renal disease.
Thank you.
You're welcome. Okay, Rob, what do you think?
It's a large.
And I'm just hoping that that's a necrotic eschar in the middle and not bone exposed, but okay, go ahead.
So it looks like we have a large ulceration with pus, essentially.
Yep.
And a raised violaceous border.
Other colors that you're seeing in here?
So I guess kind of like a lighter brown to purple.
So I agree, I'm seeing brown, and brown can be lipofuscin, melanin, or hemosiderin. I'm seeing very visible vessels suggesting that there is atrophy. I'd say I'm seeing yellow as well here. Remind you of anything we've seen recently?
So like atrophy from their corticosteroid.
Atrophy from corticosteroid, but I wouldn't expect the hemosiderosis necessarily in the yellow color. So with the atrophy in the yellow color, anyone want to jump in? Thoughts?
I think he just said.
Oh, did you say
NLD?
NLD? Absolutely. So NLD, or things that are like NLD but weirder, often with more hemosiderin, would be necrobiotic xanthogranuloma. NLD doesn't tend to be very hemosiderotic, but NXG certainly can be more hemosiderotic. So you'd look for, probably off the bat, you'd get a biopsy, and you'd look for associated paraprotein and associated diabetes as the big things you'd look for. And this was necrobiotic xanthogranuloma.
So you making a large like ulceration there on that?
They often take necro to the extremes. NLD can ulcerate as well. There is a vasculopathy associated with it. NXG more commonly.
This is the one that has the cholesterol clefting on it.
Has cholesterol clefts, has neutrophils, and the zones of necrosis, unlike the layer cake or Napoleon of NLD, it tends to form X's, telling you it is an NXG. So X-like zones of necrosis. Okay, David, what do you think?
Some overgrowth of vellus hairs.
Overgrowth of vellus hairs. So hypertrichosis lanuginosa. And do you think this is a younger or an older individual?
Older patient.
So more likely congenital familial, or more likely portends something internal disease?
He acquired some malignancy.
So exactly. So malignancy is what you're looking for. And it's a wide range, but look at gut, look at lung as common.
Like the most common malignancies in
No, but it's disproportionately gastric in some studies, not colon, which would be more common. So, some of them, like Bayes-X, cyanotic, psoriasiform ears and nose, don't tell you what malignancy, but tell you where to look. Somewhere upper lung fields, neck, whereas others tell you what specific tumors to look for somewhere. And so this is one of the ones that gastric is a little disproportionately represented, and ovarian also probably disproportionately represented. And then you have breast and colon and lung, which are just more common malignancies. We've moved on to a theme of noses.
It looks like there's some, can you tell if that's just follicular scale or spines sort of?
So question, is that follicular scale or are they spines? They look kind of spiny to me, right? So
I would think of the viral cause in transplantation.
So in a transplant or AIDS patient of a viral-associated trichodysplasia, absolutely would be a very good thing to think. What other thing causes follicular spines like that on your nose? So viral-associated trichodysplasia absolutely is one. Anybody want to jump in? Myeloma is the other. So myeloma-associated follicular spines would be the other concern. And I believe that one was myeloma-associated. Okay, so this is on the upper thigh in a woman who bleeds like crazy every time she nicks it, shaving her legs.
There's some sort of like capillary malformation.
Like some kind of capillary malformation, and it's been progressive. And how might you describe the border?
Angioma serpiginosum.
Angioma serpiginosum with that distinctive serpiginous border. And it's a dilatation of existing vessels. It's not really a proliferation of vessels. It's a weakness in the vessel wall where they continue to dilate and bleed easily when nicked, and has the characteristic serpiginous border, which is how it gets its name. But this one was pigmenting purpura. And that maybe, well, either one can give you a little hemosiderosis. You can see maybe a little yellow-brown in the background. I honestly would have put angioma serpiginosum higher on my list, but that's apparently what the biopsy showed. Okay, how about this one?
This makes me think of the gyrate erythemas.
Gyrate erythemas with a trailing scale. So you're thinking of erythema annulare centrifugum. Mm-hmm. What shape is that typically?
Typically annular.
And annular oval or annular round?
Annular oval. Round.
You are correct, annular round. And whereas this is distinctly annular
oval.
Following?
The cleavage lines.
Or skin tension lines. So annular oval following tension lines.
Like pityriasis rosea?
Like pityriasis rosea. More likely than EAC, which does tend to be more round.
Okay.
So it looks like there's a bulla on his hand, but then there's the vision of.
So what are you thinking?
Thinking it's some sort of either a worm I don't know.
Or a worm you do know. So what would be the worm you do know?
Migraines on the
Yeah,
hand?
exactly.
Okay.
So, people handle dirt and things. It could be the cable guy who had to go under the house, and anywhere where there's animal excrement, you get larval migrans.
Areas there, so I guess probably want to get an X-ray or.
So an X-ray would be a good idea. If you have fusiform spindle-like swelling of the bone, that is most characteristic of what internal disease?
Like
Not so much Mafuchi's with a spindle-like on multiple joints. That'd be sarcoid, would be much more likely, and especially if you have upper airway involvement and lupus pernio, that goes with the spindle joints of sarcoidosis. So that would probably be really high on my list. It doesn't look particularly inflammatory like a gout, and it doesn't look like it's ablating the skin markings the way you would expect things like rheumatoid nodules, reticular histiocytosis. You'd expect to stretch out the skin markings. So, very odd. Obviously, you're going to be a biopsy diagnosis if there's nothing on X-ray. And these were deep GA, pseudorheumatoid nodules on biopsy. Little odd presentation there.
So we have hyperkeratosis along it's like the lateral margin of the...
Yeah, so dramatic hyperkeratosis, color of the scale?
It's kind of like a whitish yellow.
Yeah, some of it's yellowy, which is carotenoid or serum, and others are distinctly white. And nails normal or abnormal?
Abnormal.
Okay, so what kind of things do you think?
So, like a psoriasis.
So psoriasis would be my top 40. So psoriasis usually has a white scale rather than yellow because it's distinctly devoid of serum. Where do you get spongiosis and serum in psoriasis? What locations or what forms of psoriasis? Anyone want to jump in? So acral is classic. Acral, inverse, guttate, and erythrodermic. So acral, inverse, guttate, and erythrodermic psoriasis are spongiotic by their nature. Other psoriasis is not. So a eczema rule-out psoriasis on a palm or sole biopsy is usually fruitless because you're going to see something that has some crusting and has spongiosis in either one. Other things, chronic mucocutaneous candidiasis, possibly a malignancy-associated keratoderma, less likely to affect the nail. Keratoderma climactericum is probably a perimenopausal form of psoriasis. So all roads tend to lead back to psoriasis on that one.
Well, notifying erythematous nodule, central Eschar, necrosis.
Yeah, so it's central black eschar or eschar, you can say it either way, with surrounding erythema. What kind of things are you thinking?
Arthropod.
So arthropod, and especially what kind of arthropod carrying what kind of disease?
Guessing like spider bite.
So spider bite absolutely could do it. Spider bite can give you a central eschar like that. Anthrax can, cutaneous diphtheria can, but you also see it with rickettsial disease. And so rickettsial, you'd be thinking either a tick or in New York City, a mouse mite carrying rickettsial pox. And this was rickettsial.
So there's some areas, papules, involving the lateral campus. You could also do some
So lupus miliaris disseminatus faciae, are they very discrete or is there confluent erythema? Yeah, so it really doesn't match LMDF. LMDF are really discrete BB-like papules.
also, seeing that there might be some vesicles, worry about like HSV.
So like vesicles, papulovesicular, you might think of HSV. What else?
I can't tell if there's lateral loss of lashes.
So lateral loss of lashes versus just plucking.
Yeah.
So tinea faciae, you always have to think of tinea incognito. Anyone else? Allergic contact, or steroid abuse, or steroid abuse, or steroid abuse, or steroid abuse. Steroid rosacea would probably be top of my list for it, although everything that was mentioned has to go through your mind, and I believe that was a steroid rosacea. Okay, how about this one?
I would biopsy it.
You would biopsy it. You would have done a good thing, because anything from basal cells, sebaceous adenoma, maybe there's a little yellow in there, acne agmenata, Rosi Dorfman, all kinds of things, and that one was a Rosi Dorfman.
Lower leg, looks like some petechia and purpura.
And the pattern of the purpura?
Stellate.
Stellate, going to retiform, right? It looks like it wants to form a net-like pattern. So stellate, infarct, retiform purpura brings you to what kind of differential?
The vasculitis.
So if it's vasculitic, it's which side, venous or arterial?
Arterial.
So arteriolar, larger vessel vasculitis, or something occluding an arteriole, which could be thrombotic or embolic.
Right, so all the cryoglobulins, cryofibrinogens, antiphospholipid antibodies.
Absolutely. So a coagulopathic disorder, an embolic disorder, septic embolus, PAN, that whole list. And I believe that one was another PAN. I'm sorry?
Scurvy.
Scurvy would be top of everyone's list. Corkscrew hairs, perifollicular purpura, and follicular hyperkeratosis. So, this is the slide I like to use to say, what makes you a dermatologist is the fact that you can walk in to the room and tell this old person, son or daughter who's with them, that they're not eating right, they're not taking care of themselves, and they have scurvy, whereas no other physician on earth could do that. So, it's your diagnostic acumen that makes you worthwhile. Okay, how about this one?
Okay, so there's areas of hyper and hypopigmentation, but it doesn't look so much salt and pepper like you think for scleroderma.
So scleroderma, the salt and pepper, is distinctly perifollicular, correct, which you see with repigmenting vitiligo and you see with scleroderma, and that doesn't really fit that pattern.
I mean, the first thing I thought was just disseminated lentiginous, but that doesn't explain.
And it could be someone with just nevile lentiginous, cherryangiomas, but it definitely looks like you have some erythema and then white macules as well, right?
Looks like a nevus anemicus type of picture. Maybe.
So it could be a superimposed nevus anemicus. It could be something like an MF or PRP starting on the background where you have those little islands of sparing. It could be something poikilodermatous, like a dermatomyositis that tends to give you white avascular areas. Those would all be in your differential. And this is just basically poikiloderma of Savate, someone with massive tanning bed abuse.
Looks like we have it's pretty prominent two-tone coloring of the nails. Like half of it is like a whitish gray, and the other distal part is more reddish, along with some distal level debris.
So there's erythema of the nail bed, there's some whitish discoloration, there's certainly either a partial anonychia or atrophy of the nail plate. And in this case it was taxotere use, which gives you a lot of changes around the nail, as well as acral erythrodysesthesia. And this may actually be a manifestation of acral erythrodysesthesia, acral erythema of chemo, which Taxotere is famous for.
Some areas of like sparing of the lower legs. Kind of larger. It looks pretty deep. Larger ulcer in the right upper thigh.
Larger ulcer or very superficial erosion.
Okay, superficial erosion. It's not like bleeding.
Yeah, and it looks to me like maybe the skin is bunched up there, like you've had a recent Nikolsky sign.
Okay. Okay, and I do see maybe there's a blister in the left upper thigh as well. So, I think like a drug rash.
And if this is drug, what end of the drug spectrum are you concerned about?
The TEN.
I would be very concerned about the TEN end of the spectrum with that kind of erythroderma and grayish areas and fresh Nikolsky sign, suggests epidermal necrosis and possibility of rapidly evolving TEN. And then there's the question, do you get them to a burn unit? Do you put them on cyclosporin? Do you put them on IVIG? And the problem is data are mixed now with very poor comparative trials. But you do see a trend to centers starting to move away from IVIG and towards cyclosporin. So,
What dose of cyclosporin do you use?
like 5-ish, like high psoriatic dose. And so that's a closer look at that denuded area. So did your patient start on cyclosporin yesterday, Sean?
I was going to tell Jess. So we were discussing sending her to the burn unit, as I told you.
Okay.
And so I called them to feel out, if they would take her, and the decision hadn't been made to take her. And apparently, we're going to let her kind of decide a little bit because she's been progressing so slowly, and as a result, because the burn center only does IVIG and they don't do cyclosporin, I didn't want to.
When the burn centers do what they do.
Yeah.
So some of them do nothing other than supportive care, and interestingly, some of their data is as good in outcomes as centers who do use IVIG. It's very difficult to get comparisons, but they do whatever their protocol is.
Right.
So.
And so because of that, and because we may end up sending her, we started IVIG with the presumption that at least she'd have continuity of.
Okay, so that it would be a continuity of care with what our area's burn center tends to do for TEN. Okay, and that makes perfect sense.
What dose do they give?
They use 400 milligrams per kilogram per day, infused over 24 hours, continuously until they see clinical improvement, and they do aggressive debridement of the skin with biologic dressing.
So 400 milligram per kilo per day. So your dose range is somewhere between 2 and 4 grams per kilo per day given over the 3 to 4 days is about your dosage range if you're using it. And your biggest risk is probably pulmonary sludging, vascular sludging, and pulmonary embolism from the IVIG during that time period.
We're not debriding her here. I mean, because
So fluid and electrolyte monitoring for sepsis, debridement, and cleanliness is next to godliness when they do have widespread slough to prevent sepsis, are sort of your guidelines.
So, we've kind of advised them to leave the flaccid blisters intact at this point.
As long as they're sealed and there's no septic risk, that's reasonable to leave the flaccid blisters intact. Okay.
So you have, there's onychosis in that second digit with some mentioned infectious hemorrhage.
So onycholysis, maybe a little hemorrhage, maybe a little distal yellowy, almost oil spotty nails, and then how about the rest of the nail? Normal?
It's very pale, so
One might say white.
background, like erythematous dilaceous with skin.
So I'd say leukonychia, and I agree there's a little bit of erythema, but not connective tissue like dilatation of vessels in the proximal nail fold.
I'm not sure if it's like true leukonychia versus leukonychia that's from lymphedema, which is.
Although the leukonychia often is underlying edema. And so, I mean, this is a leukonychia, and I think this was a Robert Wood slide. If the Robert Wood residents are joining us in conference, shoot me an email if you guys remember what the underlying diagnosis for the leukonychia was. And with that, I think we've got one last slide here, and then we got to head to clinic.
I'm not sure about location, but it looks on the right-hand side, it looks like you have kind of...
Maybe an ankle or a wrist.
Okay. That looks atrophic on the right, and then you have more kind of papular lesions.
Yeah, and the papular lesions maybe correspond to any pre-existing structure.
Maybe perifollicular.
Maybe follicular, and papular, and maybe papulopustular even. What kind of things would you think of?
I mean, anytime it's perifollicular, you have to think about PRP, but the color to me is not right for PRP here. I mean, AJEP, if you have pustular, can be perifollicular.
So PRP, AJEP, but again, color,
Yeah,
this
isn't
is a
that
little
right?
more erythematous than you might expect. No background erythema like you would get with AJEP, acute generalized exanthematous pustulosis. So there is some background scale. So maybe a Mycosis, especially in someone who's used Lotrazone, the work of the devil.
So you use Lotrazone on the right. What is it? There's like a huge pocket of atrophy.
There is an area of atrophy. So whether that's true and unrelated, don't know. This is a little scale, maybe the same foot with a little peripheral scale. This is...
That looks like tinea.
Yeah, and I suspect all of these are pictures of tinea. And if tinea, this is probably just erythematous, but if tinea becomes hemorrhagic, look for why they have no platelets. They could be leukemic. They could be thrombocytopenic from ITP, from lupus, but they have no platelet for some reason if their tinea has suddenly become hemorrhagic. So those are all things to consider. Okay, for next time, we are on slide 166. We're doing better with our pace. We want to hit somewhere between 75 and 100 slides per hour is what we're going for. And we're getting there. Each time we're covering a little more. So 166.
Thank you.
If you want, after this, I have a slide